So I'm Nick. I'm the CEO and co-founder of Kerrie. Kerrie is a Brisbane-based machine learning and data science organization that works with clients around the world and has a particular focus on healthcare and healthcare research. I also organise, for those of you who don't know, the Queensland AI meetup and have done for the last 12 months or so. And this is our first online meetup, which is really exciting. I have a bit of an announcement to make before we kick off today, and that's that over the last 6 months or so, a group of really great Queensland businesses have been working together to set up a consortium to really help drive both the meetup group and the broader Queensland AI agenda. And those businesses are IntelliHQ, the AI Academy, KJR, and 9 Points. And we're being supported by UQ and QUT, who are both represented on the panel today. So there's going to be a range of announcements coming out over the next couple of months. Everything is very uncertain, as we know, but we're really excited to share with you some of the plans that we have. But today is a great way to kick off what we're trying to achieve and a really important topic to be talking about. So the panel we've got together all have incredible backgrounds and incredible viewpoints. I think for me, what's most exciting is that we have both deep data science expertise, but also clinical expertise who understand data science. And so we can see the world from both viewpoints and have a frank conversation about how data science and machine learning and AI can really assist the globe in the response to the coronavirus crisis. So without further ado, I wanted to let our panelists introduce themselves and maybe just touch on how they're currently engaged in the coronavirus fight. I might start with Lucy, go to Sally, go to Kerrie, go to Jeremy, and finish up with Brent, if that's okay.
So my name's Lucy Shinners. My background is ICU nurse of about 20 years and now working as a nursing lecturer and course coordinator at Southern Cross University. As an educator, I'm really observing the growing use of technology in the healthcare system and how it's impacting the delivery of education, as well as the healthcare workforce and the patient. So my PhD pursuits are really focused on exploring healthcare professionals' experiences and perceptions of artificial intelligence in the delivery of care, basically in an effort to really try and help prepare them for its implementation in the future.
So me next. I'm Sally Shrapnel. I'm a lecturer at University of Queensland in physics and data science, and I used to be a GP for about 20 years. And my involvement in COVID is I am part of a study called ECMO Card. So this study started with a Brisbane intensivist who had a lot of foresight, and in December and early January said there's something going on in China that we should be worried about. And he set up what was initially just a little study trying to capture ICU data to see if there were any clinical insights that we could get. And it was just Southeast Asia, and it's grown and grown and grown, unfortunately, just like the virus has. We now have 250 sites across 43 countries. The US has just come on board, UK, whole of Europe, 6 continents. So we are actually in a position where we're capturing data to be able to look across the whole gamut of the world and what's happening with the hope to introduce, to be able to uncover some new insights because what we're seeing is this disease is very different from anything that we've seen before. That's me.
Over to you, Kerrie.
Okay, I'm Kerrie Mengersen. I'm a Distinguished Professor of Statistics at QUT, and I'm a Deputy Director in our Centre of Excellence that we have in Mathematical and Statistical Frontiers. And the reason I talk about that is because we're linked to 7 other universities and a number of partners, and various people across that network are working on aspects of modelling and analysis of COVID-19. And I'm also then Director of our new QUT Centre for Data Science, and that has a network across QUT of concentrations of expertise in data science across health, economics, other areas of business, environment, and so on. And so we've just had a call for people across that network who are interested in contributing time and resources to for data science in the fight or the analysis of COVID-19. My interest is also, we have a number of international teams engaged in the modelling and analysis of COVID-19 and trying to look at predictions and the impact of the interventions in different countries. So this is across the world. And looking then at also the uncertainty of those estimates, which is of course a really big part. One of the other big parts, of course, is that because people engage and governments engage with these numbers, then of course there's this two-way street with between the cases or how you're predicting, and then also how people are responding to that. And that's really where the sort of the AI interplay comes to be, because people are engaging with the data that they're seeing, which makes modelling difficult, because models are representations of complex systems, and this is a really complex health, social, economic system.
Awesome. Jeremy? Oh, we haven't got you.
Probably got to turn it on, you think? Yeah, okay.
Much better.
I'll do that then. I haven't had a lot of sleep for a few days, so apologies. This is, well, no, this is as good as I get, I guess. Jeremy Howard, I'm focused on deep learning at Fast AI and University of San Francisco, teaching, developing, researching. My connection with COVID is I made the terrible mistake a few weeks ago of deciding to teach a lesson about kind of evidence-based data analysis, and I picked masks, specifically the public wearing of cloth masks as my topic. Turned out to be super important, and the reason that was a really bad idea is that as a result I spent my last 3 weeks doing nothing but studying and talking and thinking about masks, which is just the most boring thing in the whole world. But if anybody wants to know how many droplets of saliva come out when you say the vowel A and how that compares to the weave and the average type of cotton cloth, I'm your guy.
We'll be asking you those very specific questions through this webinar. So Brent, did you want to introduce yourself?
Hi, I'm Brent Richards. I'm an intensive care specialist from the Gold Coast. Was director of intensive care for a long time. My current position is I'm medical director of innovation at the Gold Coast, as well as director of critical care research. But in terms of COVID, I've been pulled offline for that to actually help steer the COVID response, the intensive care response for the state of Queensland. So I'm deep into purchasing large amounts of equipment, looking at a whole range of equipment options, shall we say, some of which are approved and some of which are not. But what we're also seeing is how fast the organisation has to and can move, and it is moving very well. But also the value of the data as we move forward, because people are wanting to try and make more and more of these decisions based around data. But that data is quite disparate. But with a little bit of effort, we can pull a lot of that data together, and we're certainly making some efforts to do exactly that, to pull it into a data platform and to put dashboards up so that we can get better views across, not only across the unit, but across the state. So the upside of all of this is that people are really starting to value the data that we're already collecting and valuing the need to have it connected in a way that we can use it in real time.
It's interesting that trend, you know, everyone touched on, is using data to make better decisions. You know, and I think that's somewhere that I want to start, is sort of asking the question about data literacy and statistical literacy, really. I mean, there's been an insatiable appetite by the public for more and more data on COVID, yet, at least in my life, and I'm sure that it's similar for you all, is I've been asked really basic questions about the representation of that data. Why do they put it on a log scale? Or why is per capita relevant or not relevant? I know that there was a big debate on Nate Silver's Twitter recently about whether per capita was relevant in the pandemic or not. I mean, I think for me, the takeaway was that we, you know, the public are more demanding of data-based, evidence-based insights and policy than they've ever been before, but maybe not as equipped as they think they are. I might throw to Kerrie first to think on that, and then we'll go from there.
Sure, thanks. That's a really good point, and I think really, really important. I mean, people need to be, we all need to understand about data and have a level of data literacy. And if ever there's been an imperative to do that, then this is it. So we talk about reading, writing, and arithmetic, and you know, the next wave really is about data and data literacy. And it's not just about the data, but also about the analysis. So we see the predictions of models and and some of those are not compatible with each other. They're giving contrasting inferences and contrasting estimates. And so there's also then around that is the need to understand uncertainty. And you know, each of these estimates comes with a plus or minus, and we need to be able to understand about that plus or minus as well. So there's a huge need to have data literacy, and that's so that we can ask intelligent questions, but then also how do we actually engage in that discussion with the data and what that data is going to mean for us in our lives.
Jeremy, before we got on here, we're having a really interesting conversation about that, you know, the conversation should be not what ML and AI can do to help with the COVID response, but more broadly data science and everything that entails. And also about some of the decisions or calls that are being made by the WHO on the way that they approach evidence-based, you know, the way that they're viewing evidence in this crisis.
Yeah, so there's been this string of disasters from the WHO, which I'm sure people are pretty familiar with now. There's been the statement of there's no evidence of human-to-human transmission. And that was WHO. Then the WHO said there is no evidence of asymptomatic transmission. And now we have, there is no evidence of the efficacy of the public using cloth masks. Each of these cases are cases of where people have failed to adapt to the fact that our understanding of statistics and evidence has changed a great deal in the last few decades. Each of these statements actually meant there isn't a randomized controlled trial with a p-value less than 0.05 that proves these things. But the American Statistical Association guidelines actually state that we should not be using p-values as the basis of the main basis for health policy decisions. You know, what we should instead have done is said, use the real word evidence to mean like, is there any sign of human-to-human transmission? If there was a sign that there might be there, what would be the impact of responding now as if there was versus if there wasn't? You know, and if that discussion had happened, the asymmetry of the utility of that, along with the kind of level of preponderance of evidence either way, it would be very obvious to say, let's assume that there is, because if there is, we're, you know, got a lot of people going to die. So we have the same thing now with these stupid damn masks, which is like the preponderance of evidence, you know, 53 out of 54 studies strongly suggest they're a really good idea. They could be the most important tool we have. They could literally save millions of lives and hundreds of billions of dollars. And at the cost of like 10 cents per person, would that be a good idea to use versus the downside of like lots of death? So this idea of evidence and kind of data-based policy has really been a disaster over the last few months, and I think it could well be described as being the number one source of the problem we're seeing is a kind of statistical reasoning mistake.
I might throw to Sally for your input here.
I just got a very quick comment to make that there's a fantastic paper by BMJ from several years ago, which is a randomized controlled trial for the use of parachutes in gravitationally challenged individuals. And it's a comedy paper that they got through that basically says sometimes you don't need a randomized controlled trial, right? And the end of it is they say, we suggest, like, we're having trouble recruiting for people for this trial. So we suggest that all those people out there who keep saying you can't do that until you have the randomized control trial should take part in this randomized control trial on the efficacy of parachutes. Anyway, there's been a few follow-up papers, so I just thought I'd add, you should all have a look at that one.
You know, it's actually incredibly similar, because the reason we don't have RCTs on masks is that nobody's been able to go into a hospital and say, all right, nobody's allowed to wear masks for the next 2 weeks, you know, because everybody knows it's a bad idea.
Yeah. So can I just follow up with a comment on that? I think that they're really, really important points, and we can use different kinds of tests and methods now to be able to assess the efficacy or compare different options. But we still do need to make those kinds of assessments, and they do have to be rigorous assessments, because obviously, I mean, there are costs to any decisions that we make. and there is variation in the data, and so we do need to be able to distinguish, like, what's the signal and what's the noise.
Can I say, though, I mean, I feel like part of the issue here is this assumption amongst folks on the medical side that the decision to do something is a decision and the decision not to do something isn't a decision. Whereas to me, the decision not to hand out masks is a extremely dangerous and costly decision, but because it's a decision not to do something, no one ever has to justify it.
Yep.
I'm going to use that point as a convenient segue to talk a little bit about that that relationship between clinicians and providers of care and public health officials and the data science community. And start, you know, I want to start with actually a bit of a debate that's been raging that, you know, this isn't the time for, you know, data scientists to have their time in the sun. They should probably step back and let, you know, clinicians, epidemiologists, public health experts do their job and sort of butt out, for lack of a more eloquent term. I mean, do we, you know, as a panel, do we agree that there is an important role for data science and machine learning to play? And how do we how should we counter some of those comments? I might throw to Brent and Lucy as people that have come from the clinical side of the fence.
At the moment, we've got so much going on that, frankly, we need as many hands on deck as we can get. And the more we can get people to help us with data and who actually understand how to work with data, how to extract it, how to work with it, how to work with missing data, how to impute at that level, and then to turn it into something that is at least understandable by a clinician, is actually in a great shortage at the moment. So in fact, we're at a point where we actually need more of it than we've ever needed before, because part of it is that we're scrambling to actually understand what's going on. And it keeps changing in front of us. So we need as much help as we can get in that space. So I think it's almost the opposite, that we actually need as much help from the data sciences community as people wish to give us, because we are really chasing our tails in this to try and stay ahead of the evidence.
Yeah, and to add to that, I think, you know, down at the clinical level, we're always playing a game of catch up. And, you know, for clinicians, their focus is just the patient in the bed beside them. And so, you know, you talk about the whole data literacy piece. I think there's a lot of catch up that we have to do yet to really understand the value of that data that's being created. For some facilities, they're only just moving to a fully digitalized setting. They know they're creating data, but they don't really understand just how much value we can get from that data. So there is a lot of work yet to do in that space. And unfortunately, with the whole crisis, it all has to happen very, very quickly. And at the end of the day, the clinician just wants to provide really safe care to the patient and do the best that they can. So as Brent says, I think it's right. We need as much help as we can at the bedside. We may not have a good understanding of just how important that data science space can be, but yeah, there's a lot of work that needs to happen yet to really bring them up to speed. I
will say, though, as a data scientist that had the temerity to weigh in on, you know, a kind of a discussion around this, there's always a few gatekeepers who jump in and want to jump on top of you for not staying in your lane. And they tend to be not, in fact, they're never really people from the medical side. They're always like fellow AI researchers who told me to leave it to the experts. But like, who's an expert on the use of cloth masks for COVID-19? Like, we become experts, but, you know, and studying the data is a great way to do that. And, you know, through, you know, so I decided to ignore those people, and, you know, quite quickly was literally talking every day to senators, helping them brief the CDC, you know, helping get through these policies, which eventually got through to the WHO. Like, data scientists can absolutely make a difference. But, you know, the trick, I think, is to, as a data scientist, is to make sure you stick to like showing what the data says. And in this case, the data includes like what a peer-reviewed studies say, stuff like that.
We do have a poll about how we think that ML or data science can be used. So I'll get Rowan to throw that one up, because I want to switch to Sally and ask the question, you know, working on the ECMO card, which is more in your clinical decision support space, how have you gone engaging clinicians all around the world, and the clinicians that are probably at the, you know, right at the pointy end of the response to this? Have they been receptive of the work that you've been doing? Has it been hard, that collaboration?
Yeah, so I would say my experience has been the opposite. The clinicians have been, and so we have a Zoom catch up every 4 or 5 days with all the clinicians involved, and they are absolutely 100% on board, and you know, saying this is where we are going to be able to figure out how we can make a difference in this pandemic, is actually engaging data scientists. I think the thing is, if you're dealing with people with that kind of flexible mindset, who are prepared to engage in an iterative approach, it's going to work. So the thing is, because we're building data approaches and solutions, and even just very simple dashboards with pie charts, but involving the clinicians, what do you want to see? And they find more disease, they come back and say, we're wondering about this and this. Are there any techniques that can pull apart these two variables or show that there might be correlation here? And then we go back and say, well, yes, there is, but you know, we can't guarantee that that's a causal relationship. That doesn't mean that if you do an intervention, it's necessarily going to change. You know, and there's just this lovely open dialogue to and fro. And I think necessity is the mother of invention, right? Because we really, really need answers soon. People are prepared to be a little bit more open-minded than perhaps in usual times. The ability to work across disciplines, and I think now is a really good time for people who are prepared to be a bit open-minded to make some headway in these challenges.
And I think, you know, the ECMO card is an interesting example of how data collection has been rapidly scaled up to deal with the pandemic in front of us. Data sharing in the, you know, in healthcare has been a challenge for a long time. I'm interested to throw to Brent, who's been quite involved in some of this stuff. Are we seeing some of those traditional barriers to data sharing come down in this pandemic, and is that a good thing long term?
So people are certainly starting to talk about sharing more. There's still the usual hurdles to get through, but people are getting much more, shall we say, open to that. I think that in part because we've been talking about it for so long that we actually know what most of the answers are anyway. Reasonable de-identification is exactly that, reasonable de-identification. Federated learning is exactly that. It doesn't, you can, you know, keep your data sovereignty and still actually have your data analysed. You could even use homomorphic encryption. There are technological solutions as well as legal solutions, as well as fairly straightforward answers to a lot of the questions. Also, is what's happened is that the tipping point has started to occur, that most of these questions aren't going to be answered from a single data set in a single country. And so there's an absolute imperative to start to share and to share fast. And so I think that's actually starting to change the rhetoric. And is what we actually hope is that it actually changes the rhetoric for good rather than for once.
Yeah, I think what's, you know, beyond data, what's traditionally been a challenge for data science working in the healthcare space has been translating models from, you know, computers into the clinic, and the range of challenges that comes with, from, you know, explainability to uncertainty to causation, and to actually just physically delivering you know, an insights model to someone working, you know, walking the rounds in a hospital. I might go to Sally to talk a little bit about some of your work in explainability, and it sort of touch on whether you think that we're going to have the same challenges of translating to the clinic for what's being built now as we've had in the past. You're just on mute.
Oh, sorry, unmute myself. So my own experience in explainability came from a desire as a clinician. So I saw these great papers that could use CNNs to differentiate between skin lesions. And for me as a clinician, that's just a game changer. That is so something I want. I want a reliable clinical decision support tool for that problem. It's a really hard problem. And so what I wanted to do when I looked at those algorithms, what you see is you get this nice value on an unseen test set. but you kind of want to know more because you know the AI is not perfect. It makes some mistakes and you want to know what the mistakes are. And the current state of play with explainability techniques is pretty much that most of them, what they're good at is showing you failure modes rather than why the models, you know, I think they're not so good at telling you why a model has made the right decision, right? They can show things up, but it's still kind of too coarse grained. But what you can see is if a model's made a decision on something really stupid, you know, some obvious spurious correlation that it's learned that you don't want to be basing your decisions on. So at the moment, the techniques are kind of a bit of a filter. There are 20,000 papers every year on explainability techniques. Like, it is really a booming business. It's very hard to keep on top of the literature, and there's a lot of stuff in there that's noise. So there's a lovely paper that came out last year called Sanity Checks for Saliency Maps, where they showed a lot of the maps. So these are, you know, you get an image and you stick it through your machine learning model and it gives you an outcome like, you know, yes, there's the tumour. And then a saliency map basically says which are the pixels that matter, either for that particular image or for the model as a whole. You can do either. And they showed that a bunch of those saliency methods, you know, you could completely scramble your model or you could completely scramble the data. And in either case, sometimes those explanations don't change. So we know those kind of explanations are pretty rubbish, right? So, and there were a lot that were being used. So I think there's a bit of skepticism crept in about whether explainability techniques were really explaining what we want to. So that's something that's getting a lot of attention. In terms of bringing it into the COVID discussion, I think it is that thing of having the domain experts involved all the way along, because what they do, you know, at some point you come up with something and they want to know more details around it, and then you go back to the model and go, well, what can we say about this model with respect to that question they're asking? So again, it's just that kind of iterative approach. We use the domain expertise to look at the features that are of interest, and then we kind of feedback that way.
I'm going to come back to domain expertise because Mark's put through a great question on the Q&A. But I wanted to jump to Lucy because we were talking earlier about, you know, there's one area of explainability, which is the technical explainability. Can we reliably do saliency mapping or, you know, produce Sharp values, etc. But there's another, which is actually giving that not just to clinicians, but to nurses and to patients themselves, and that level of translation from a technical explainability to a one that makes sense to a practitioner or a patient.
Yeah, I think as Sally said, in that regard, you know, translating it right down to the patient and the clinician, the whole inclusive design piece is incredibly important. They have to be involved in the project. And I think if you want to find people that can help you do that, you need to go to the space where you want to implement your technology. The clinicians need to be involved so that they understand it and so that they can then go on and explain it to their patient. You know, so much of what we do is translating care decisions so that the patient feels confident about the journey that they're on. So I think that piece is incredibly important. You just cannot leave the clinician out. They're a key part of this whole journey. And yeah, I think patient explainability is incredibly important. Once again, it's such a rapidly moving crisis at the moment that it's going to be really difficult to explain that quickly and easily without them feeling unsafe. But it's still a piece that needs to be followed up and put through to them, I think. So
definitely. You know, to go further to that inclusive design question, the question from Mark was to Jeremy around, you know, what's the importance and how important has it been during the Masks for All process to work with a range of very different stakeholders, as you said, you know, cloth experts and, you know, the sort of very broad range of skills that need to come together to produce that paper.
Yeah, it's been critical. So, I mean, absolutely critical. So we've got a paper coming out in the next couple of days where I've put together I think what is the first international cross-disciplinary expert team around everything to do with masks. And so, for example, we have a top sociology professor on it who is looking at questions like how do we deal with the stigma and behavioral situations associated with people of color in the US? When people see them in a mask, you know, we've literally now got videos of police going for their guns when they see a black person in a mask. How do we deal with compliance? We've seen situations in Mexico where attempts to use masks has resulted in very low compliance due to a lack of trust in the government. You know, there's a lot of these issues to deal with. So we put together this kind of cross-disciplinary team, and we all, you know, this being the year of COVID, we're all hacking away together on Slack, and it's been the most collaborative, you know, week of my life. It's been amazing. And so the example Mark was asking about here is, for example, you know, could it lead to people unconsciously dropping their hand hygiene standards? And so thanks to this cross-disciplinary team, I now know that hand hygiene seems a lot less important for COVID transmission. Being respiratory, it's really actually all about the mouth. And one of the really interesting behavioral things is people touch their face dozens of times every hour. You can tell them not to, they still do. And the thing we care about is it actually doesn't matter if you touch your face. It actually matters if you touch the inside of your mouth or the inside of your nose. And if you have a mask on top, then behaviorally speaking, you stop doing that. So there's all kinds of interesting second order effects. We've also been working with disadvantaged communities in Africa and people who have been focusing on that. And they've pointed out that for tuberculosis, this really critical disease, there's still this huge stigma around mask wearing. If you're wearing a mask, you might have TB, and then you get shunned by the community. Anything that can get more masks on people is going to really improve, you know, TB outcomes as well. In fact, in Hong Kong, the flu is 50% less flu this year because more people are wearing masks. So yeah, all these second and third order impacts and, you know, different disciplines coming together, it's so important. And data scientists can play a really good role as a kind of a, you know, I'm the dumb person in the middle who doesn't understand anything, but I know how to like put the bits of the data together.
I wanted to sort of unpick a little bit more on the question of translating to the clinic. And I think what's an important discussion to have is, especially in like a clinical decision support sense, is how we deal with, you know, neural networks that are overconfident or systems that are overconfident by their nature, and particularly working with the small data that we generally have at the start of a pandemic like this, you know, what some of the techniques are and how important they are to incorporate in design. So I might go to Kerrie first and then jump to Brent for his input.
Thanks. Yeah, certainly when we don't have very much data at the beginning of a situation like this, then we are looking at, there's been such a proliferation of papers, even in the early stages, and now even more proliferation of papers giving different kinds of models and different kinds of activities touching the face. And so we have lots of different approaches to understanding and modeling those data. And each one of those has slightly different techniques, and we do need to have that sort of confidence assessment on that. And so it can be around, there's uncertainty in the model itself in how well that represents the system. And then there's uncertainty in the predictions that that model's actually making as well. So you can start off with not having very much data, and actually the results of that model could really be, if you're predicting, could be very diverse potentially. And then you have something that happens. And so that changes the shape of that uncertainty, but then you get a different kind of set of predictions that come from that. So you're doing this, and with you know, the collection of models, so you're coming up with this ensemble of uncertainty and the predictions going forward. And understanding that, I think, is really important, and trying to unpick that. Because if, for example, we're going to look at trying to compare different interventions, so we might go country to country and say, Hong Kong did this, and France did this, and Italy did this, and Australia's doing this. And the results of that were a flattening of the curve that looked like this. Well, in fact, that flattening of the curve, whatever we see, is just one realization of many potential outcomes that particular intervention could have had. So we need to understand what those potential outcomes could have been if we're going to compare this intervention with this one, and then make policy decisions going forward. Is it a real difference, or is it just the fact that we've seen that single pathway, and how sure are we about that comparison that we're making?
Mm. Brent, I'm interested to know if measures of uncertainty are useful in a clinical setting, essential, or is it too much noise for clinicians who are having to make lots of tough decisions on the fly? You're on mute.
I think they want to know their decision support. That's clearly there, but a few things is that firstly, yeah, at best 20% of our practice is covered by a randomized controlled trial, and it may be way less than that. So firstly, the level of evidence we're working on a day-to-day basis may be far less than what people may understand. Mm-hmm. Secondly, even when there's a randomized controlled trial, you put it up against whether this suits or fits my patient, whether the trial actually fits my patient, and often it doesn't. So this isn't just an AI problem. This is a challenge that we've got in every piece of research that we've got. The third thing is that clinicians are fallible. If you actually look at a lot of the good AI studies, they're actually looking at the fallibility of clinicians. And frankly, we're way more fallible than many of us wanted to believe. But it's there. And some evidence is often better than no evidence, as long as you've got some understanding of what's created that evidence and what sits behind it. And look, it's not just AI that we're in this space with. If you actually have a look at the history of cardiac catheterization and stenting, is that the literature took a decade to catch up with the change in materials that were being floated, and they just kept improving. And the AI algorithms are in the same place. They will just keep improving. You've got to keep monitoring, but at the same time, you can't sit there and wait. So I think that with this stuff, it becomes a decision support. It's not a decision-making mechanism. People need to be made aware of the vagaries of the data and the vagaries of what's sitting behind it. But at the same time, it will continue to be helpful rather than just standing back and waiting, because if we stand back and wait, we'll be making a decision in a vacuum.
Yeah, absolutely. Jeremy, I'd be interested to know, and for sort of people that are listening that are budding data scientists or people currently in the process of maybe transitioning careers into data science, are some of these topics, particularly around explainability and uncertainty and causation, covered in the Fast AI course, and have they become more important over the couple of years that you've been running it?
No, they haven't become more important. It's been a critical part of my work for the last few decades. I actually started a company called Optimal Decisions back in 1999, and we helped insurance companies set prices. And the way we did that to set a price was to not just make a prediction about risk, but make a prediction about how likely somebody is to accept a certain price, and to create a complete simulation of the next few years of the company and all of its competitors in the marketplace. And that eventually got turned into an article about data products. So, it's always been critical. I guess it's just getting more attention now because data science and machine learning gets more attention. One thing we have done is we used to have two courses, one called Introduction to Machine Learning, which had maybe half of it was about explainability, and a second one, which was called Practical Deep Learning, which only had a tiny bit of explainability. This year, we're actually combining them for the first time. We've released a book, or about to release a book, which the course is based on, and it just integrates it all together now. And I think that's a good idea, is to kind of say, so we've got data ethics, we've got explainability, we've got kind of classic decision tree ensemble type approaches, all integrated into a single curriculum. And I've just started teaching that curriculum, and on the whole, people are really liking it. This idea of bring us all together into a single place.
It makes a lot of sense. I'll put the call out there. We've got about 15 minutes left, so if anyone does have any questions, please send them through, and we'll do our best to get through them. One really great question from someone on the line was, does anyone have any great initiatives for independent data scientists to get involved with to help with COVID?
I'll start just with this. The Academy of Science has actually put out a call for experts for COVID-19. And so if there are any people out there who are interested in registering any kind of expertise, but that's a place where they can register it. So if you search for Academy of Science register COVID-19, then you'll find it.
Also, you can go to forums.fast.ai, forums.fast.ai, and click on the COVID-19 category, where lots of people are asking for and providing help around data science and COVID-19.
One of the biggest question trends that I'm getting through the Q&A and multiple on the same topic is really around how do we, how do people find data sets or training sets? How do we get better training data out there for data scientists to use? But probably more importantly, how do data scientists do more with less? How are they able to leverage the small amount of training data that has been released so far to create more robust models that might be more useful earlier? Anyone have thoughts on any of that from training sets all the way up to doing more with less?
Yeah,
Sally?
Yeah, so if you're interested in clinical stuff, particularly around the ICU space, there are some really great publicly available data sets, like the Mimic3 data set from PhysioNet. And there are lots of questions coming out around how we should manage ICU patients, and the possibility to do transfer learning there is going to be really important. So having, there just aren't that many people that have done really good machine learning projects on those publicly available big clinical data sets for people with, it's ARDS, adult respiratory distress syndrome. So we know that coronavirus produces cards, but it looks very, very different. The clinical picture is different. But using publicly available ARDS data sets, of which there are quite a few out there, to do and to produce some models that we can use for transfer learning would be something that would be useful. There's also the Allen Institute has put out a bunch of publicly available data sets. I think there's a Kaggle competition using some coronavirus data from China. I'm not sure what the quality of that data looks like, but there's some other options.
Jeremy, it looked like you were, sorry, go on.
Oh, I mean, the magic word's already been said now, transfer learning. So transfer learning helps a lot, rather than starting with a empty model with random parameters that doesn't know how to do anything. Try to start with a model which knows how to do something as close as possible to what it is you want to do. Unfortunately, in medicine, there's very few pre-trained models available. There's no good reason for that. Honestly, it's a bit of a travesty. And, I do a lot of work in medicine. I'm the chair of a AI medical lab at my university. And we're always struggling with this issue of like, oh, if only we had a pre-trained model, we could answer your question. But since you don't, we're going to need 100 times more data. So that would be something which institutions and data scientists could make a huge contribution to the world, would be to create and release pre-trained models for medical data sets and medical problems.
Sorry, Kerrie, it looked like you were going to add something in there.
Oh, I mean, there are sites starting to spring up with combined data sets. Johns Hopkins University, of course, has the good global data sets, and also links then to other sites as well.
It's an interesting question that should there be mechanisms in place before events like this to ensure that data can be released faster than it normally would be? Brent, do you think we'll see a change in public policy to enable data sharing in light of these sort of circumstances?
I would hope so. I've got some discussions somewhere in that space this afternoon, but some of what's also happened is that some research studies have been set up after H1N1, so more than a decade ago, which have actually been sitting waiting to go, and the trigger's been pulled on them. So they're actually in process. And what that does is it almost preempts the occasion without actually releasing data. Now, that's an internal data set, but I think that we're going to see more people wanting to have that preemptive ability. But what's also important in that is not just the release of data, but the understanding of the data. So what Sally was talking about, which is to get your teeth into the data that's already out there. There's a lot of work you need to do in the space as a data scientist to actually understand the data. For intensive care, it's to understand what an Apache and a SOFA score is. That Glasgow Coma Scale is not a number, but it's a categorical variable. Things like that take a while to understand. And so I think that there's the work in that space is to actually understand the vagaries of the data as we start to ramp it up, because there's a lot of vagaries in clinical data that take a while to understand.
You're not wrong there. I guess the question is, how are you prepared to translate the data information to people at a time like this, when it's probably not a reasonable request to call an ICU physician and ask them what that variable means? Yeah,
I think that it's a small amount of time and effort to get to that point. There's enough people around who want to help, and the question set's not that big. It just takes a little bit of time, and there's a lot of good online resources that can lead you through that, the simple questions. But yeah, as you say, accessing the data remains the fun part. Sally?
Yeah, just one of the things that we're working towards in the ECMO card project is putting together a data dictionary for people around these kind of problems that we can release publicly. It won't have any patient data in it, but just a resource. So we're building on our Slack channel a resource because as more people come on the project, they need that quick start in knowledge to be able to understand the domain, etc. So we're just trying to build a tool like that that we can then release publicly. And I think anyone who's working on coronavirus data at the moment, that should just be part of your project, so that more people can come on and get that quick onboarding kind of mechanism.
And I just think the Australian Intensive Care Society have actually got a very good data dictionary based around their data sets. It doesn't mean you can get access to the data easily, but it's a very good data dictionary.
Jump in, Kerrie.
I think of there are the sort of the scientific papers and the sort of the theoretical and methodological work, and then there's the interpretation of that by sort of the applied data scientists. And similarly, there are the patients and the clinicians here, and then it's like we need the intermediaries as well. So as well as having a register of data scientists, it'd be really good to have a register of people who aren't on the front line, so they do have time to talk to you, but actually then, so who do I go to ask about questions like this when I want to engage? And I mean, we're really fortunate that we have lots of good connections in that area, but for many other people who want to get into this, then how do they form those teams? And having that kind of register would be really useful.
Yeah,
definitely.
I agree too, from the clinical point of view, in that, right now we're all scrambling to find these connections and teams and things, but if we want to prepare better for these sorts of projects in the future, it'd be really good to get something a bit more formalized. And I think you could pull that right back through to, tertiary education to identify people's interests and make those connections a bit more formally. So that there's a lot more, discussion between the two, and you can have those interpreters, that can see both sides of the picture. Yeah, I think that's very important.
You sort of need like a dating app, a professional dating app.
Yeah.
We're sort of down to 8 minutes to go, so I wanted to round off on a nice and broad question that that everyone can sink their teeth into and have their point of view, because I think one of the challenges with discussing, data science in the age of COVID-19 is, to me, it touches every area from public policy response all the way through to clinical trial design and everything in between. And so it's hard to have a conversation about, data science and COVID-19, because it's basically like, what can data science do? Full stop. I'm interested from the panel to discuss, what applications or what current work in data science or AI and COVID-19 actually makes you more optimistic about the course that this virus could take had that, intervention or had that work not happened. I might throw to Lucy first.
I think it's been really powerful, actually, and I think it's given us an insight that we probably weren't expecting and allowed us to prepare better than what we would have if we didn't have that knowledge and information, to be able to see modelling and trending and then see that work its way right down through to how it's managed at the clinical level, I think has been extremely important. And it probably would have been a very different story if we didn't have that predictive capability to kind of see what's ahead of us, how do we plan before this arrives. So yeah, it's been very interesting.
Sally?
Well, for me, because I'm 24 hours a day looking at our data, I would say the thing that's been interesting for me is being able to look at data from around the world. It's obvious that there are some real differences pathophysiologically about this disease, and you know, we haven't released this stuff yet, and but you know, this will become available as we get more confidence that the numbers that we're seeing validate what we're seeing. But the fact is, once you have enough data, you can really start to see how things are different to other diseases that we know a lot about. And that's the real important point for me, is seeing that this really is it's nothing like the flu. It's nothing like SARS. There are some real obvious changes, differences there. And if we weren't collecting this data in this manner, we just wouldn't.
I think that's been an interesting theme of the panel generally, is how a number of conceptions have been held from early on in the course of the disease where we didn't have a lot of data, and some of them have been very difficult to shake, you know, and have persisted despite evidence to the contrary, and probably to the detriment of the response generally. I might throw to Brent next for your thoughts.
Yeah, look, some of it is also, it's been good to look back and use that to understand what it is we normally do. A good example is we've looked at what our drug use has been in the past, because we asked everyone what drugs they would normally use in the situation and what they said they would use, and when we went and queried the data sets and had a look at what they did actually use, we got lists that were fairly similar, but there was some big omissions and when we actually looked in the data. But which people hadn't been considering. At the same time, it means that if we're running into an area of shortage, we can say, well, there are other ways of doing this which seem to be working equally well in other situations. And then it gives us a question we can continue to set up and monitor as we move forward. So there's some very big ongoing uses of data, which is part of the preparation as much as the understanding, which becomes very useful in the space.
I might go to Kerrie next for your thoughts.
Yeah, I guess for me, the optimism and the sort of the silver lining of this, I guess, has been that we've really seen a drawing together of different communities. That's you're working as data scientists and then linking to not only the health sector, but also through to the business sector and through to the social sciences sector and so on, and seeing how those different sectors interact in this this kind of pandemic, because it's not just about health, of course, it's about all of the aspects of our society and our environment and everything that's being affected. And so, you know, we play a role as data scientists in engaging in those various aspects of the pandemic. But even within data science, I mean, we tend to, even though from the outside it might look like one area of data science, AI, machine learning, etc., that kind of solid core, but in fact it's very easy for us to set up our silos as well. And I think what this has done is really bring us together as a community and say, well, we need the skills from all of our mob as well. And like, you know, we need to be talking much more. And I think that those barriers now will be much lower when we go forward. We'll all have our own skill sets, but we'll certainly be working together to be able to then link to these other broader challenges that we'll see going forward. And finally, I think the silver lining is that, you know, we have much more awareness in our communities now, in the general public, about data and the need for data science and data literacy. And if that's a Kickstarter for us then to be able to continue that kind of data education, then I think that that'll be a really great advantage for the future.
Absolutely. Jeremy, I'll let you get the final word.
Well, one of the really cool things for me to see has been the way the technology community, particularly the San Francisco Bay Area kind of tech startup community, has come together in this amazing way. I spend kind of all day, every day across lots of WhatsApp groups of people I've never met before, never come across before, that just is kind of spontaneously organized. And, you know, for example, when people saw my Masks for All campaign kind of taking off, somebody, you know, reached out and said, you should speak to this guy. And this guy turned out to be somebody who had set up this thing where now if you text Masks for All in the US to 50409, it will walk you through a process in text messaging that will send a letter to your governor and your legislators demanding mandatory mask laws in your state. And like, it's just such a cool example of, you know, and then, you know, somebody else reached out and told me, you know, which governors they know, and they have this group that's figuring out how to do advocacy direct to governors. And, you know, it's been really cool because, and we've needed it because there's been a really disappointing amount of kind of intentional misinformation, you know, intentional because there's been this approach where health policy decisions are being made to like literally lie to people or to ignore things. And I wanted to mention before we finish that Australia is actually on the bad end of one of these decisions. There's been a health policy decision not to talk about seasonality. And the reason that health policy decision was made was there was a concern that if people started saying that this appears to be seasonal, then I don't know why, but people always mention Brazil, that everybody in Brazil is going to not do social distancing. They're going to get sloppy, and you know, the assumption that if you tell them that this is less bad in summer than winter, then they're just going to be idiots. So there's a lot of these health policy decisions where people are being either lied to or not told, you know, going to be being misled on the assumption they'll be idiots. So unfortunately for Australia, that's put Australia in this terrible position where very few people in Australia realize that this is extremely likely to be a highly seasonal disease. Modeling I've seen suggests that the R value is going to double into winter. And so, you know, you're going to be from a situation where it kind of can grow by 1 or 2 times over a month to one, you know, where it can grow by a few dozen times over a month. And Australia is going to be kind of apathetic because I'm hearing from my friends in Australia, oh, we're on top of this, we've knocked this on the head, things are going better for us than Italy or New York, when actually it seems that's almost entirely because of seasonality. And so Australia is going to be one of the first, you know, in the Southern Hemisphere, it's going to be one of the first countries that's going to deal with a complete winter. Nobody's had a complete winter of COVID-19 before. And I'm terrified for my friends and family about what this means. And I just don't see Australia putting in the effort to put in the massive amounts of testing, tracing, mask wearing, you know, systems in place so that Australia is ready to be what I suspect could be the hardest hit, one of the couple of hardest hit countries in the world over the next 6 months.
So not the most positive note to end on, but an important note. And I think it's, you know, a really, you know, really important points you bring up around, you know, the communication of some of these policy decisions and where policymakers have decided to leave things out of the narrative to, you know, support other concerns, Brazil being one of them. That is absolutely all the time we have for today. I want to thank the whole panel for taking an hour out of their extremely busy schedules, made even busier in this time. You've all been so generous, so honest, and everyone has contributed a huge amount to this conversation. So I really thank you. We will release this as a recording at some point, so people that missed it can tune in. But thank you all once again, and keep up all the amazing work that's happening.